that is out there. There's not a lot of research on IBM and swallowing, but I was able to go into a few journal articles, and over the last maybe 5 or 6 years, they've been studying the deficits in IBM, like what areas of the swallow are affected. The primary area that's affected in IBM for swallowing are those muscles in the throat, the squeezer muscles, the contractor muscles, the muscles that push food and liquid down into the esophagus. And if those muscles are weakened, then food, liquid can kind of hang out, stay in your throat. Some of you might have that sensation that there's something stuck in there. I feel something in my throat. I don't feel like I've cleared it all the way out. I need a sip of water, perhaps, to wash things down. Another area that's affected is the protection mechanism to keep things out of the airway. And I had a lot of questions from you guys about aspiration, about things going down the wrong pipe. So we know in IBM, some of those dynamics, some of those structures in our throat that protect our vocal cords can be impacted. The epiglottis is a flap. It's a little flap that's in our throat. It covers up our airway when we swallow, and it keeps food and liquid from going into our airway. Sometimes that is affected as well. Also, the chewing mechanism. There is some discussion that the oral phase in the mouth, you take a cracker, you chew it up. Perhaps the tongue isn't working as well, and therefore the tongue's not able to gather that cracker, clear it out between the teeth and the gums, and get it into a nice cohesive form to swallow. So those are some of the primary areas of IBM that are affected as it relates to swallowing. And practically speaking, that means you may go out to eat and you may order a nice dinner and realize you can't finish it because something isn't cooked the way it needs to be in order to go down easily. It might stick in the throat if those muscles are weaker, or you may have difficulty chewing something because the tongue is weaker and you're not able to kind of get things into a nice cohesive form to swallow. So that's where speech therapy comes in. That's where I come in and my colleagues come in. We're there to evaluate a patient swallowing, and we're there to help a patient mitigate those problems that you might have when you're eating and drinking. That can be done through evaluating the swallow, a modified barium swallow. I don't know how many of you have had a modified barium swallow or have them periodically over time. But that's a radiologic swallow study under X-ray where we're able to dynamically watch a person swallow. We can look at that oral phase, what happens in the mouth. We can look at that pharyngeal phase, what happens in the throat. And if we're really looking at the big picture, we might want to look down at the esophagus too, and just make sure everything's making it down into the stomach, okay? As far as treatment is concerned, once we've done that swallow study, once we've gathered that information about what areas of the swallow may be impacted by IBM, then we're able to help a patient make decisions about what are the appropriate food consistencies that might be more beneficial for eating, that might be easier. What changes in how we swallow might make swallowing safer or more efficient? And if it's appropriate, based on that swallow study, are there any exercises that may benefit the strength of the swallow and give patients more opportunity to eat and drink the things that they like, and to do so safely. My goal is to create positive outcomes outside of my office. I want my patients to be able to go to their favorite restaurant and eat perhaps some of their favorite foods. How can we make that happen if possible? Do we have to make any changes? Do we have to make any modifications? But can we still create that enjoyment? Can we still create that positive experience for people? Because we eat for enjoyment. We eat to live, yes, but we also eat to enjoy food. It's nice to go out with family. It's nice to celebrate holidays. It's nice to be able to enjoy food and liquid in as safe a manner as possible. So as you all are aware, IBM is a slowly progressing disease of the muscles. There's muscle inflammation and there's muscle fiber degeneration, and it makes those muscles of movement weaker. And that does include, the swallowing muscles, as we've just talked about. One person asked me in the questions what the percentage was for people who have swallowing problems with IBM, and the data supports that anywhere from 65 to 86% of all people have some semblance of swallowing problems. And I think on your poll that we did there, that kind of told us that there's some degree of swallowing impairment for many of you that are experiencing IBM. Another question was, how quickly does the swallowing issue progress? I think it's variable. Obviously, things vary from patient to patient, but we know that IBM is a slowly progressing disease. So we would imagine that in most cases, there's always exceptions, but things change slowly over time. So I think that in a way that may be positive in the sense that we can, if we stay on top of things, hopefully we can keep people from having, problems from the swallowing issues getting ahead of the patient. The other thing is that a lot of you asked, how do we get a referral to a speech pathologist? And I, certainly recommend that you reach out to your physician, your provider, whoever the person is that's managing your care, whether it's an ENT, another physician, and they perhaps know somebody, hopefully in your area, that it can at least get you started with a good swallowing test. Even if you're not having a tremendous swallowing difficulty, a baseline swallow study is a great idea, just to see where you are and if there's anything that you could do to mitigate problems going forward, kind of staying one step ahead of things if possible. I know some of you may live in areas where accessibility to a big medical center isn't feasible. Honestly, I think that's okay. I thought a lot about that after talking to Nancy a little bit. If you get to a big medical center, great, but most good speech pathologists that have training and experience in dysphagia, in swallowing, can conduct a very good swallowing test, can give you all of the information that you need, and more than likely can start you on the appropriate diet recommendations, modifications that you need as far as what you would eat, what you would drink, and how you would do so, and certainly swallowing exercises as appropriate. So, finding a referral source in your area may be challenging to some. Again, you don't have to go to a big major medical center. And, again, Nancy encouraged me to learn more and more about IBM, even though I had some experience. There's not a lot of you out there everywhere. So, a good therapist will sit down and, just read the literature a little bit and help understand the disease process and what to expect. There's not a lot of literature out there. Another big question that came up that I wanted to address was treatment for the muscle at the top of the esophagus. A lot of you asked me that question. There is a muscle that sits at the top of the esophagus. It's called the upper esophageal sphincter, or the cricopharyngeus muscle, okay? And it's a circular muscle. The design of this muscle is once we swallow, food and liquid pass that muscle, and then it tightens up again to prevent reflux, to prevent things from coming back up through that muscle. That muscle is one that is potentially affected by IBM. So that's why sometimes people have difficulty getting solid food into the esophagus. Another reason for that backup there in the throat. That muscle can be evaluated by a swallow study, by the swallow study that we talked about. It can also be evaluated by GI. They can do a test called manometry and test the pressures of that particular muscle. But one of the questions came up, does Botox help? Does dilation help? Does cutting that muscle help? I read all the literature on that before I came on this talk today. And it's kind of mixed. I think it's a robust discussion with your gastroenterologist and your speech pathologist for sure. Perhaps your ENT surgeon who might be doing some type of surgical intervention is really important. A lot of times that muscle will become hypercontracted. It'll be too tight, and managing it with dilation or with a surgical intervention or potentially Botox has been discussed. The problem with just going in there and cutting that muscle is that if the muscles or the structures above that muscle are weak, it's not going to necessarily help that weakness. It's only going to relax the muscle. So um, that's a kind of a mixed bag there. Like I said, I read a lot of different information on that, and I think you have to have a good discussion with your uh, providers to determine if that's a good idea or not. So anyway, exercises on swallowing, that was another question. There are some good swallowing exercises out there that can focus on various aspects of the swallow, strengthening those squeezer muscles, improving tongue function and mobility, helping with airway protection. And those exercises are those exercises are good as long as the right ones are chosen. So I think, again, getting that good swallowing test and that good visit with the speech therapist and looking at the swallow as a whole and figuring out what is weak, what is not working well, and streamlining those exercises to work the appropriate muscle groups. I think that's really, really important. So I could lay out a whole list of exercises for you, but they may not be the appropriate ones for your particular problem. So, so that, something to think about. I'm looking at the chat. It seems like many providers are quick to say that cutting that muscle is the thing to do. This is often asserted without the swallow study or understanding what is causing the specific problems. Totally agree. That surgical procedure is called a myotomy. We talked about that muscle being a ring, okay? What they do is they basically longitudinally cut that muscle and relax it. There is no reversal of that particular surgery. So once that muscle is relaxed, a couple of things, you are at a greater propensity for reflux then, because that muscle is our protective tool to protect our upper part of our airway from acid reflux coming back up. So if that muscle is cut, sometimes reflux becomes much more problematic for a person. And as it was mentioned here, that swallow study is so important because you could have that muscle here that's not working as well. However, if the muscles above it aren't working as well, you're still not going to swallow well, if that makes sense. So again, it's looking at all of the different elements of swallowing. There was a question about Botox. Can it make aspiration risk worse? It is another means of relaxing that muscle at the top of the esophagus. I looked at the literature, I looked at the data. I only found it really in one article, and it said it doesn't necessarily work, although some people have had good results with it. I can see that in the chat too. So I think, again, a good robust discussion with your gastroenterologist or your ear, nose, and throat physician, whoever is doing these procedures, and the speech therapist after a good robust swallowing test, maybe, and what works for somebody may not work for everybody, because even though there is a nice they're trying to get a good idea of what's causing the swallowing issues in IBM. Everybody is a little bit different. So I think it's important to, get those good swallowing tests done and get as much information as one can, if that makes sense.
And Brendan, I think this is all absolutely fantastic, fantastic information. What I'd like to be able to do
Sure.
now, or we'd like to be able to do, is get into some breakout sessions so that we can
Absolutely.
all talk about the information that Brenton's got for us and talk about it and come back and let her really get into a little bit more, another half an hour of our specific questions. So with that, let's get into, Sharon, our breakout rooms. We're going to, yeah, do you want to take this over, Sharon? You're probably on mute. What we're going to do is to get into some breakout rooms. We're going to do this for probably each, when you're in the room, about 20 to 23 minutes. Why don't we do breakout rooms with 8 people in them?
Okay.
Okay, so do you want to set up the breakout rooms from here? Once you're in there, you're going to click to join your designated breakout room. You're going to meet the people that are in there and select a person as a timekeeper or facilitator to keep the group on task and just allow everybody to participate. Also have somebody as a reporter to gather information. So one person, that reporter, will be a spokesperson when we get back to the whole group. Be aware of the time allotted and allow everyone to talk. So with that, Sharon, let me have you turn it over to you. Let's set 8 people for 23 minutes. How's that?
Okay, and so here are the two questions that we want to discuss, and other things will probably come up too, and that's wonderful. And forgive my voice today. I've had a lot of trouble with dysphagia the past couple of days, and I've had lots of coughing, so that's why my voice sounds like this, so appropriate for today. But the two questions are, how does dysphagia impact our lives physically, emotionally, and socially? And so we want to make sure we talk about that, because that the whole issue of swallowing and aspiration and everything impacts several areas of life. And then what has been most effective for you in managing these challenges? So we do want to hear what you have learned to be helpful. And I'm seeing that our group is starting to drop. I think a lot of them wanted the information from our speaker, and then they're dropping out. Maybe they'll come back at the end to hear more of it. So we're down to 60 people now. So I'll change the size, the number of rooms. Okay, well, and it's still changing. All right, so we'll go with this, and whatever numbers in your group, go ahead and do the task, and we will get started. Join your room and we'll get going.
Thank you.
Oops, I'm sorry. I'm gonna recreate them real quick. Now they're too big. I'm gonna go up one more. Okay. Okay, I'm gonna ask a few people if you're going to join. Dodie, were you joining your room? And if so, click on there to join, because in this room, the main room right now, nothing will be happening. I'm just going to be admitting people. Linda, please join your room. That's, yeah, Linda Walter, Linda Patterson. You can join yours. Norma Bellows, if you'll join your room. And it looks like, and Avis Ramos, if you will join your room. Just so you know, if you don't join the room, you'll be sitting here for 20 minutes just waiting for them to come back, which is totally fine, if that's what you want to do, but we'd love for you to be able to be in one of the rooms, and you can join and just you can join and just listen in. You don't even have to talk if you don't want. And we have, let's see, do we have
I
somebody that
can't see where to join.
who's speaking?
Linda.
Oh, okay. So Linda, I think you just came in, right? That's why you,
Actually, I was in and somehow I got bumped out when I tried to join the
okay.
breakout.
Tell me your last name because
Patterson.
Patterson, let me find which room you were in. Wow, I don't see. So I'm going to go ahead and assign you to one of our smaller rooms. So we'll make sure you have plenty of time. So I'm gonna assign you to room 7. Okay, do you
I
see
see it.
Great, great. Okay, those who are still in this main room, if you don't have a room to join or don't know how to join, unmute and just ask me and I can, yes,
Sharon,
yes,
Sharon, hi. I was in 7, but could you please put me in a different room?
sure.
Thank you so much.
And who's speaking right now?
It's Beth Chiati.
Okay, Beth Giatti,
Thank you.
sure.
Thank you.
You're welcome. Come back if I need to reassign.
Sharon,
Yes.
this is Claudia.
Hi, Claudia.
Would you please put me in a room?
Okay. And were you not assigned or?
I clicked on the wrong thing and said not now,
Okay.
but I mean,
Okay, I'm looking to see if I can, there you are. Okay. Yeah, you were in room 5. I'm trying to even out these rooms as much as we can. Okay, so here we go, Claudia. I'm gonna put you in 6. Okay, how about Avis? Am I saying that right? Avis Ramos? Did you want to go to one of the rooms? And Linda Hatchfield, did you want to go to a room? I'm going to try to get you there. Let's see. says that you, Avis, you're connecting to audio and you can't hear me yet. So let me see, Avis. I'm gonna see. How about you, Susan? And then Linda Hatchfield. Linda, if you want to unmute, you can ask me if you want to be moved to a room. Okay. Susan Sweeney, if you want to be moved to a room, you can unmute and let me know and I can get you to a room. Avis, I see that you're trying to connect to audio and you can't hear.
Would. One of our members talks about having a life bath in a bowl on the table and talking with her dinner guests or her house guests to make sure that they know how to utilize that in the case that that were needed, which we thought was really a great proactive approach. And we also spoke about using various medication formulations, liquids when possible, or having tablets cut into smaller pieces to be able to make sure that they're palatable. So did I leave anything out, group members?
Bren, do you have any comments on their group?
Yeah, the only thing I wanted to touch on was the EMST, which is the expiratory muscle strength trainer that a patient or a person in this group mentioned, and just kind of the rationale for use of an EMST device. If someone has it, there it is. Jane has one up there. It's an expiratory muscle strength trainer, and just it's not designed to strengthen swallowing muscles. But it is designed to improve respiratory strength for the cough reflex, which actually helps us clear our airway if we have potential material, whether it's saliva or we're swallowing it. It helps improve cough force and cough strength. And we know that cough is so important in, again, managing anything that might be threatening our airway. Like I said, whether saliva, liquid, food. So I just wanted to kind of point that out. I do use EMST for some of my patients. It's good for people with respiratory problems, respiratory weakness, helps improve muscle strength. There's another device out there called the breather, and the breather coach. I think somebody asked me that question in the questions. That device is on Amazon. Like I said, it's called the breather. It strengthens both inspiratory, the air that's coming in, and expiratory, the air that's going out, those muscles that are involved with that. So I will often use it to strengthen cough for swallowing or swallowing protection. So just to kind of give you a little more insight on what the EMSD or respiratory muscle strength trainers do. So speak with your speech therapist to determine if that's something that would benefit you from airway protection in swallowing. A good tool.
Thank you. Okay, group 3. Anybody from group 3?
I think that's me.
Didn't assign anybody, but I have some notes if you'd like.
Okay.
We had one person who did have some surgery, but not the sort of controversial one, had identified very individualized problems that in her system that the surgery could help. In restaurants or any eating, we talked about knowing what textures you can manage and what you cannot. We talked about in restaurants, sometimes you can ask that food be, particularly meats, be cut in the kitchen to avoid the embarrassment of somebody trying to cut it for you at the table. And most restaurants, if you're a little insistent, will do that. And some of that's a swallowing problem. Some of it's a hand problem that we can't manage the utensils to get the meat cut. Some people found bubbly water or juice to be more effective than just water, and found that ordering that or having that on hand would make a difference. Some folks had ongoing therapy, whether it's a personal trainer or home health, for physical or occupational therapy. We didn't really talk about that happening for speech therapy, but it seemed like that model is one that would help us all, instead of practicing first with the therapist and then going home with exercises to do now 3 times a day for the rest of your life. That little support would make a difference, as it does when you have return physical therapy appointments, and that maybe people could arrange that support for themselves simply by scheduling follow-up appointments, even though the therapist said, you're all set, take these home and do them for the rest of your life. Well, maybe we should just schedule a 6-month appointment, and maybe that would help us to be more compliant with the exercises. And it did come up in the context of physical therapy, and we're not sure if it relates to speech therapy, that anybody who's worried about getting their Medicare coverage for physical therapy cut off should go Google the JIMO settlement that we were told about of months ago, and then take that to your therapist,
And
and let them use it.
yeah, and Janet, thank you very much. Brent, I'm gonna let you expand on any questions. But Janet, one of our next year program is going to be a follow-up on the GMO and some of the PT regulatory things that are going on.
Yeah,
So,
yeah, basically Medicare sets up a therapy cap. There's two levels of caps. One is kind of a first level cap, physical therapy and speech therapy. This is for Medicare, okay? So you're straight Medicare. This doesn't typically apply so much to your Medicare Advantage plans or to your traditional insurance, but this is straight Medicare. And it's around $2,000 a year that's initially allowed for PT and speech combined. OT has their own $2,000. The whole concept of PT and speech being together has been a problem, but it is what it is right now. There is a secondary cap, which is basically $3,000. And after that, somebody reaches the $3,000 cap, then really the onus is back on the therapist themselves. We often go past the $3,000 cap. The idea, especially with Jimmo versus Sebelius, which is the law that Nancy was referring to, is that as long as these services are deemed medically necessary. So if you're looking at a patient with dysphagia who is at high risk or even mild to moderate risk for aspiration, as long as I, as a clinician or a provider, can document and prove that my services are necessary to help maintain or improve function in a patient or prevent additional problems in a patient, then generally speaking, Medicare will cover it. I have surpassed the $3,000 mark in various patient populations, and to date really haven't had any issue. The onus really comes back on the provider, though, not the patient. You guys will
and
not
and
get
it's
billed with that for that
it,
amount of money. We will lose the amount of money if Medicare ever denied it, the facility or the provider would. So,
it,
you know,
we could go on. That's so I'm gonna
that's
table
a
that
whole big
conversation.
topic. Yeah.
Table that conversation to the beginning of the year
Yeah.
when we have already targeted some people from APTA
Yeah.
and to speak about it nationally.
It's not
So
it's not as hard a cap as some providers will make it sound. So, keep
yeah,
that in
yeah,
mind, that there is opportunity for therapy. Don't look at that as a hard cap. It's probably my,
no,
yeah.
we're all there. So yeah, we got a lot with PT. So I was in group 4, but I don't know who wanted to talk about that. Whoops, ladies.
Connie Brown.
Martha, you were a great note taker. Connie was the person. Okay.
Well, both of us kind of, but we talked about, yes, that it was definitely very socially isolating in some ways. One of our members had a problem with eating and then bowel control, so that was that's definitely hard for her to do. And I suggested I have invited people to my house when then I can serve what I can eat, like soup and things like that, and just something to keep our friends, our circle of friends in our lives, and whatever that takes to do. And a lot of times eating out is not the best way to do that. And also we all eat so slowly. I know that's a problem. One of our group said that milk products were causing her problem and creating a lot more phlegm. And then we had 2 people who had excessive salivation, which is the opposite of some of us who have dry mouth. And she suggested, her pulmonologist suggested Robinol, Robinul, which inhibits salivation. And so that helped her a lot because she had always has to have a something to hold to, that she can spit in or whatever. Some people have said, and I agree with this, that sometimes carbonation helps. And we had different results with dilation and Botox. Mine has lasted about 3 years when I don't choke as much, not as good as right after it happened, but actually that's quite long for most people. And some people have it just doesn't help. And I don't know if Botox always goes along with it, but it did in my case. Then we had a person who was diagnosed in 2018 who had aspirational pneumonia right now, or she's being in a rehab, and she has a feeding tube, and she said it progressed very rapidly just since June. And I had a question myself with a feeding tube, then you actually cannot swallow anything, right? Is that correct?
No, actually, it depends on the patient. I mean, if a patient is determined to be unable to swallow safely, then perhaps they may not be able to swallow, and then they require a feeding tube. However, we talked in our little breakout group that there may be a time where people cannot meet their nutritional needs by mouth. Maybe it takes all day to get,
Mhm,
needs met.
mhm.
So when you look at the nutritional situation, a feeding tube might be warranted, but sometimes, and maybe oftentimes, people still have the propensity or the capacity to be able to swallow small amounts, liquids, soft solids, sometimes even regular solids for pleasure. And so you kind of get, again, your nutritional needs met without the pressure of having to take everything by mouth. Medication administration, some of those things can go through the tube, but enjoyment, the socialization, some of those things that are so important with swallowing can still be maintained.
Thank you.
And that is it's sometimes people, certainly in my office, if someone suggests the G tube, they're concerned that we're just taking away all swallowing, and that is not the case necessarily.
No.
Thank you. That's great information.
And-
We're running a little short on time, so that's why I'm moving things along a little bit faster. I don't mean to do that. So let's go, and ladies, if there are questions that you think may not be answered, please put them in the chat so we can get back to you on it. Because you certainly have our email. Do we have group 5?
Yes, that was group 5, Nancy. Um, Talking about, how it affects you, and I think everyone's already brought this up, was the coping with and having decreased socialization, the anxiety associated with exposing yourself to others. Most people have a small knit group of people that know they have difficulty swallowing, but they still enjoy socialization, and it becomes difficult. So some people choose to maybe only have 1 or 2 bites of the meal when they go out. And that way they are still able to talk and join in conversations. And another person talked about, letting everybody know at the table that you have this difficulty. They bring paper towels with them. So if they can't get something down, everyone knows ahead of time that I may have to be spitting out some food and trying to be as discreet as possible. Changing of eating habits. Some people have done away with eating chicken breasts or turkey breasts or pork, because it tends to be a little drier, and they have switched to
Sandwiches are kind of hard.
the dark meats, which have more moisture to them.
Huh?
Or I know myself with pork chops, I always dip my bite into
the
some
cheesing crackers.
applesauce, or I make sure there's always gravy on things to help moisten, to make it slide down easier. Another thing, and haven't really heard people talking about much of it, is they stopped taking their pills, which actually can be hazardous to your health depending on what it is that you're not taking anymore. A doctor suggested to grind up all the pills or open the pills and put them in a food to swallow them. And another member of our group who happens to be a nurse brought up, well, if they're enteric coated, then you're not getting the effect of them if they're being dissolved in the stomach acids. So each step, it may be helpful to get the pills down, but then again, it may be harmful because it's not allowing the pills to do what they should be doing. Another thing that was brought up was voice changes.
Oh, yeah.
with this. So the biggest takeaways was anxiety, voice changes, and pill
Mhm.
swallowing, if there can be any help with that. One person in our group had the surgery for myotomy years before there was the diagnosis of IBM. And it did help for a number of years, and I did not write it down if it was still helping at this point with the IBM. So that's about the cliff notes on this, our group.
Thanks, Laura. Thanks, Laura. Greg, do you have any comments on that?
Yeah, a few things. As far as medication, I mean, medications can be difficult. There has been some discussion that obviously if you modify medication, it can change the efficacy of the medication when you take it. And I always just encourage my patients to reach out to their pharmacist and determine if there are any modifications that can be made safely and without losing the effectiveness of the medication that will allow for ease of swallowing. I would say the majority of the time my patients are able to come up with something that will be helpful with the help of their pharmacist. The other question was on voice changes. And that question came up on the questions that you all asked. I don't know if I mentioned this, I work for Cleveland Clinic as a hospital, but I also work 1 day a week, full time, that full day at an ear, nose, and throat practice where I deal primarily with voice problems. And I will tell you that I do see a small number of people with these disease types with some changes in voice function, maybe some more hoarseness, maybe reduced speaking volume. If we're looking at a change in muscle function, we think about the vocal system, the vocal cords. These are also muscles that are involved in movement. So I did pull up a few articles that I read, and there hasn't been a lot of research, but if you're looking at the idea of muscle weakness, we can certainly ascertain and determine that there may be some functional voice changes for people just a result of the muscle wasting and the muscle weakness. So and those can be addressed with therapy too. I mean, there are some good therapy interventions that we can use if you've been evaluated by an ear, nose, and throat doctor or a speech therapist at an ENT practice. Perhaps there are some additional exercises that can help that as well. I have worked with many patients in the voice therapy realm as well. Whole nother topic, but a good
Great.
question.
Thank you very much. Was there a group 6? I think there
Yes,
was.
Nancy, we have 8 groups.
Oh, okay. So let's go quickly to
Yes,
6,
we were,
7,
I'm
and
sorry.
8 because we're running out of time.
I think we
Thank
were
you,
6.
Sharon.
I can go
Yes,
quickly. This is Sonia. We had 7
thank you.
people in our group and only 5 spoke, but of the 5, only 3 of us had dysphagia. 2 of them were cerebral. One was diagnosed just last year, the other one 2018. Neither of them have dysphagia. The 3 of us that did have dysphagia, one person is using a portable suction device that goes around the mouth or teeth, and apparently that helps with secretions. Another person is actually just in the conversations about possibly getting a PEG, which is like a feeding tube. So she's in the process of trying to get more information. We all spoke about socially, obviously, it's difficulty at restaurants. I'm the one person that has dysphagia, and I was diagnosed 16 years ago. Dysphagia was my first presentation. Usually dysphagia is at the end of the later on in the disease process. But after 16 years with dysphagia, it has progressed, but I still can eat. I'm very careful with, chewing slowly and small bites and all that. But I still am, in a place that is fairly significant in terms of being able to go out socially. I'm mentioning that to give encouragement to people that, again, I've had dysphagia for 16 years. Absolutely, there's progression, but I'm still able to eat most things, go to restaurants, and not have any issues. I'll stop it at there because otherwise the rest of us just, emotionally and socially, there are issues that need to be addressed.
Brendan, any comments quickly on that one? You're muted.
Yeah, I'm muted. Yeah, actually, I was typing in my email address for everybody in the bottom of the chat because I wanted to ensure that I know there were a lot of questions, and since we are going to run low on time, I do want people to realize that you guys are welcome to email me a specific question that you might have, and I am, just give me time and I'll be happy to answer each one of those individually on any of the topics that we did not get to today, because I know there were a lot of, lot of
Right.
information there, but I'm very, very happy for you to reach out to me. So
Thank you. And I don't know if you have to go or not, but if you do, because I know you probably have patients
yeah, I have a
today.
patient at 1:45, so I still have
Okay,
a bit of time.
let's see if we can get the other quickly. But in the interim, we're gonna go through this. If you need to go, we just need to give you a round of applause and say thank you, because we're gonna keep going a few more minutes to talk about group 7 and 8 and a couple minor things. And I really appreciate everything you've done. So if I can give, let's give her a round of applause and say thank you. Um, and any comments in the chat, we will definitely have in women at IBM,
Yeah,
women with IBM at myositis.org if you have any questions, and you'll have Brenton's
yeah,
email.
I just put it in the chat. So it's jenksb3@ccf.org. Please, no question is a silly question. They're all great questions. And I'm happy to, like I said, answer any of those for you as you need. So
And if you lose her email, email us at womenwithibm@myositis.org and we will forward it to her.
and
So with that,
thank you all for having me.
again, thank you. And let's get to group 7.
Okay, I'll listen in for a few more minutes.
Thank you. Group 7. Okay.
Thank you very much.
Thank you. Thank you. Is that group 7? How about group 8? So do we have any people we have not heard from that are still here as we're on there? I think people are are leaving. Ladies. Anybody that we didn't? Okay. So Sharon, either we I think we're good. Then I'm gonna say thank you all. I was rushing everyone because I was looking for group 7 and group 8 from this. And Brighton, again, thank you, thank you, thank you. And
Welcome.
enjoy the gorgeous day that we have in beautiful downtown Vero Beach,
Will
in our
do.
small town on the East Coast. So ladies, I'm gonna say thank you to everybody, and with the coming year, we're asking if anyone who's ready to help and volunteer. There are a couple of other things that we would like to do for you so that we can help you more, and we need some assistance. So if there's anybody out there that can, that's interested in assisting us with print communications, helping with our quarterly newsletter, helping just do some of the day-to-day clerical things to keep us not keep us communicating with you, please let us know. Um, there are a lot of things that we want to do just to help you going forward. And we really need your help with that. So keeping you abreast of newsletters, what's going on with research, what's going on in our day-to-day lives. So please drop information in the chat or womenwithibm@myositis.org. Um, and with that, I'm gonna say December and the holidays, happy holidays. Oops, it didn't show up, but we had a great little fun thing in there with Thanksgiving and all of the December and January holidays. Thank you. I hope everybody has a healthy and safe holiday season. We know it's just remember, be positive and stay resilient as you go through. Um, and we're gonna keep going with that. So we're gonna pause our December meeting. On the horizon in January, a couple of things that we're going to be doing next year. We want to talk about what's going on in IBM research, especially with the T cells and all of the things that are happening now. We talked about PT and talking about best practices for physical therapy, occupational therapy. We can put speech in there too, both in the home and as an outpatient. There are so many things to talk about. We broached on some of them today with the GIMO and how to utilize that. But I think PT right now is our only medicine. We need to know how to work with our therapists, how to get the best use, the best continuation of care that we can to keep our programs going and as we continue on our IBM journey. Another topic that we're going to talk about, we hope to talk about, is the role of our, whether it's primary care physician, on our IBM journey. And coordination of care is a big thing as we move forward. So with some of us that are dealing with specialty clinics in one city, living in another, primary care, physical therapist, speech therapist, rheumatologist, um, it'd be nice to communicate and see how everybody else is doing that so that we can improve our quality of lives. And as I said, I can't thank you enough with the rest of the team for being here, and we're here to help you as you go along your IBM journey. So please let us know what you would like to hear from us going forward. Thank you for being here. And as again, here we know that IBM places significant demands on us, and we can't deny the impact, but continue to develop our strategies to enhance our abilities to thrive. And to paraphrase again, Maya Angelou's statement, we're changed by what happens due to IBM, but we are determined that we won't be reduced by it. So again, thank you. And a big shout out to Sharon and Laura, but more importantly, a big shout out to everybody who was joining us. And thank you, ladies. Have a great day, and more importantly, a great holiday season.
Thank
And
you
we'll see
very
you
much.
next year.
Thank you.
I just wanted to ask if anyone's interested in playing any kind of card game, bridge, or any kind virtually. Take my email and I'll give you the link on how to do that. is very, very satisfying for me. I found it to be very relaxing and just, old-fashioned fun. But have a good holiday, everyone, and take care. It's been a wonderful, wonderful meeting today. I'm glad I joined this group today.
We're glad you were here, Shirley. And I loved your avatar that talks.
Thank you. Yeah,
How'd you
that's
do
my
that?
friend.
How'd you do that?
Well, on Zoom, you go
Okay.
under where the camera is. You see that little arrow next to the camera?
Uh-huh.
You press that little arrow, and it says, well, mine says show avatar. It should say create avatar.
Oh,
And I
okay.
went in and created my little self. And you can actually see my mouth moving.
I love it. I love it. Thank
Oh,
you.
boy. Wow, thank you. All right, ladies, y'all have a good one, and then thank you for this group.
Thank you. Bye-bye.
Thank you, guys. Thank you.
Can't get out of here.
You'll figure it out, Shirley.
It looks like you should see something at the bottom that says leave, little red button.
Yeah, yeah. So, Sharon and Laura, quickly, what did you guys think?
Oh my goodness, I thought it was great. I'm interested to hear from you all how the breakout sessions were. The report backs were amazing. But I will tell you, it was quite busy here trying to get people back into groups when they got sent out and late people coming in. So I was pretty busy the whole time. And then right when it was time for it to start again, I had, this major buildup and all this coughing, and I was like, oh, brother, and I had to move away from the table and, grab tissues like they were saying. And
So
I calling my
what do you think about the format?
I thought it was great. Is Laura still here? Looks like,
No, I don't know, where's she? I thought she was here. Yeah, no, I think the format was good. I needed to balance more because I couldn't figure out I didn't know how many groups we had. So we had, and we'll probably, if we get kicked off in a little while, but that's fine. Um, with TMA. But yeah, the format, what did you think of Brenton?
I thought she was great, so knowledgeable and so easy, to understand. She wasn't trying to make it, real
Clinical,
professionally knees words.
right,
She just made
right.
it clear, and because she's so knowledgeable in that area, she was able to really respond to the questions people had.
What I found with her, this is strange, is I've been to Hopkins 4 times or 3 times, and one of the therapists gave me some exercises. I couldn't figure out how to do them with the therapist at Hopkins. 10 minutes with her, and I knew how to do it.
Wow. Oh, that's great.
But yeah, she brings everything down. She keeps it clinical, she keeps it professional, but she brings it down to
One second.